So I'll start by acknowledging that we all hate morcellation. I will agree. And we all hate morcellation because it is like war, in the sense that there are long periods of boredom, especially when the morcellation is not going perfect, when the adenoma is hard, interrupted these long periods of boredom with bursts of sheer panic. And this happens when you're damaging the bladder. And these are videos of me damaging the bladder with every morcellator I've used extensively. And it's a terrible feeling when you do this, but this happens. So what can we do to avoid this or to minimize this as much as possible? I'm going to talk about some basic morcellation principles and mainly about the available morcellators in Spain and in Europe. Some basic morcellation. The composition of the morcellation is very complex. These are machines with a lot of pieces, a lot of things that function differently. But the main differences between morcellators are the blades and the suction system. Blades can be oscillating, moving from one side to the other, or reciprocating back and forth. And they can be single-use or disposable or reusable. And the suction can be with a vacuum generator. It can be with a peristaltic pump, and theoretically it can be plugged to the vacuum from the OR, but I really don't recommend this option because it's usually not strong enough. So mainly two suction options. And with this we go to evaluate all the morcellators available in Spain. We have 6 morcellators available in Europe. The most common ones, we can divide them in classic morcellators, the Versacat and the Piranha, and the new morcellators. And I'm going to evaluate them individually regarding efficiency, bladder wall injury rates, malfunction of the device, and a bit of an approach to the price, but this is difficult to pinpoint exactly. And I'm going to put everything on this table that you can look or download scanning this QR code. So let's start with the beginning. The first morcellator available was the Versacat, originally from Lumenis, then bought by Boston Scientific, an American company. It is the only oscillating morcellator from all the list. The outside is sharp, the inside is sharp. This is the Versacat functioning. It was the morcellator I started my learning curve with. The main problem with the morcellator is that you don't really see the tip of the morcellator, so you have to be very careful not to approach the bladder wall because, of course, you can damage it. And this is reviewed in the available literature. From 17 studies, this is a morcellator with the most available evidence, median efficiency a bit low of 3.9 grams per minute, bladder wall injury rate of 5.2%, so very high, and a low device malfunction rate below 1%. And this is a cheap morcellator. Then we go to the Piranha by Richard Wolf, German company. This was an important change in the mechanism of morcellation. It has oscillating blades. This is the Piranha functioning, so it moves the adenoma from one side to the other. Very efficient, very silent morcellator. This is one of the 2 morcellators I currently have, and I'm really comfortable with it. It uses a vacuum pump, so it's not a peristaltic mechanism. And at the beginning, we had some problems with our peristaltic pump. We now don't, but we developed some tips for improving the seal mechanism. We put a little bit of tape between the tissue trap and the vacuum generator. We cut the length of the tubing. With less tube, the suction is more efficient. And you have to make sure that you have this rubber ring correctly placed inside the handpiece. It can dislodge usually during sterilization. And if it's not in the proper place, it will work terribly and you will not know what happens. You change all the tubing, you change everything, and it won't help. And the position of the blades recommended for this morcellator is 50% open. So what do we have in evidence? Also a lot of evidence for this morcellator. 13 studies, median efficiency higher than Versacat, 5.3 grams per minute. Bladder wall injury rate lower, 1.2%. But device malfunction higher. More complex device, it makes sense that it malfunctions more frequently. And it's also more expensive. It's a high range of expensive. Would be nice to compare these 2 morcellators. There are 5 studies comparing Versacat and Piranha. 2 of them show similar efficiency between them, and 3 show more efficiency for the Piranha. I personally agree with the 3 that show that the Piranha is more efficient, and I think everyone would, and that the Piranha needs less auxiliary procedures to finish morcellation, like resecting the adenoma, for example. And now we start with the new morcellators. The first one is a drill cut from Karl Storz, German company, oscillating morcellator with a vacuum generator, coarse blades. This is the drill cut functioning, similar mechanism to the Piranha. It makes a bit of a wobbly movement, a lateral movement of the handpiece, but I think you can get used to this. And the main difference comes in the evaluation of the studies. Very low evidence, from now on, very low evidence, very low amounts of evidence for this morcellators. The efficiency is similar to the Piranha. The bladder wall injury a bit higher, but this is a problem with this morcellation, the device malfunction rate. 7.9%, 8% of device malfunction, that is the highest in the evaluated morcellators. And it's also on a high range of the price. This is probably one of the most interesting morcellators to evaluate. Last time I was here, it was the super new thing. Everyone wanted to have a multi-cut solo. It was solving everyone's problem. It was game changer morcellator. And I prayed my boss to buy me one. He did. So you have this very nice screen where you can modify the oscillation and the aspiration. Usually you can't do that with most morcellators. It's an oscillator, and it has a peristaltic pump. It doesn't have a vacuum generator. So you have very high speed of blade movements. I usually start morcellators at 1,800 RPM, but the suction is not great, probably due to the peristaltic pump, and it dislodges more frequently than, for example, the Piranha that I also have. So some tips to improving this. So how do we improve this suction efficiency? We do a couple of three things. One is to use gravity on our side. We stand up for morcellation. This is also nice for the back. After long inoculation, my back usually hurts. But when you stand up, you put the handpiece higher than the morcellator, and it's very important for us that the drainage goes down, so you have a gravity-assisted flow of the urine. No oscillation for low speed. Javier commented on this a little bit. When you lower the speed to avoid the tissue dislodging, sometimes it gets slow and even blocked, and then you will get this warning sign. You have to stop the obstruction and start again. And you avoid this by removing the oscillation. The blades will spin only in one direction, but it's less frequent for them to jam, to get obstructed, and you will finish your procedure more efficiently. So it would be nice to have a comparison between the Piranha, this kind of the gold standard of morcellation, and the Challenger. There is a multi-cut. There's nothing published yet, but we have performed a prospective randomized study on 137 patients. It's pending publication. It's already written. And to our surprise, we observed that the Piranha is still more efficient. So the new kid on the block, in this study at least, wasn't better. And this efficiency was more pronounced in smaller prostates than in bigger ones, might be due to the need to change the canister when the prostates are big. Might be a little less expensive because it has reusable blades, but this shouldn't be a big difference. Higher bladder wall injury rate, at least in our study, but lower malfunction rate, again, probably due to the simpler mechanism of peristaltic pump. The JOS morcellator from the Hawk company is also known as the Hawk morcellator. It's a Chinese morcellator. I've tried it once. It was very nice to use. Very little evidence. There's this study by He that is not really focused on morcellation, but they report their efficiency. And this study by Eyeball that is published in a non-indexed journal. They report an efficiency similar to the Piranha and drill cut and all the rest. But bladder injury rate and device malfunction of 0%, and tend to doubt studies that report 0% of complications in anything surgical. Also, it's as expensive as the other one, so no benefit in this side. And to finish, the Cyberblade, that I'll give this morcellator the design price because it's the only one that is basically different in the sense that everything is in the handpiece. You use a battery for energy. You have no pedal. You only connect a vacuum pump. This is the Cyberblade functioning. You control the speed of the morcellator with these buttons. You start and stop the movement of the bladder with this other button, and with this lever, the suction. I would define it as slow but steady, with emphasis on slow. It is probably the slowest. Scientific evidence is completely lacking. So might be useful for a low volume practice or to have as a backup morcellator, and it's cheap, but it's probably, as I said, the slowest, and very little evidence on this. So we put everything on this table. You have to remember that the available evidence drops dramatically as you move down in this table. And that's also why I changed the numbers for more or less categories. Efficiency is, let's say, there's 3 categories of efficiency. These 4 are in the main category of efficiency. VersaCut probably has the higher bladder injury rate. DrillCut probably has the highest malfunction rate, and you need to bear this in mind. So now we're ready to go to Amazon.com and buy our morcellator and celebrate that we can start morcellating as we want to. But if we have learned some things from Titanic is, first of all, 2 people can fit on this piece of wood, and the other one is that sometimes the developers of a machine exaggerate the good attributes of their machine. Remember that God himself could not sink the Titanic, and of course it sunk. A morcellator is a machine, and it will fail, and you need support to fix it and to not stop your enucleation program for long. So consider after-sales service as well. You can get this, as I said, this table scan in this QR code. I'll leave it up here for a moment. And to finish with some take-home messages, when evaluating a morcellator, consider efficiency, but also safety, reliability, price, and after-sales service. And to summarize the comparison between the classic and the new morcellators in one slide, this would be it. All the new morcellators are based on the Piranha design. Having said that, it is good to have many different options and competitions against different companies. Thank you very much for your attention.
Thank you, Ivan. Great presentation. Any question?
I have a question.
Okay.
Ivan, congratulations, because your presentation is wonderful, always very clear. So for me, it's very interesting that every single company, we have more and more lasers, TFL, Superpulse, Tulio, Holmium, and blah, 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 more and more and more lasers. And for me, the limitation of this technique, it is not the laser, it is the morcellation. I am tired of doing enucleation. It takes me 45 minutes to take 200 grams into the bladder, and then I spent more than 1 hour trying to do it, and it is difficult because the ball is in the bladder, and then it's hitting the wall, and then it begins bleeding. You cannot see.
We all hate it.
The beach balls, you cannot eat it, and then you take the resector, and you are. So for me, the limitation of the technique is the morcellator. Which one is your opinion, and in which way do you think we should be working in the next future to improve this?
I absolutely agree. There have been attempts to improve this. They would develop this bag that put the adenoma inside the bag, inside the bladder, and then morcellate more efficiently, but it didn't really work out. I know that some companies have tried like completely different designs for morcellators, but they didn't work out. I think it's difficult because it's dangerous. You have a high rotating blade inside the bladder, so you have to be very careful about what you develop, and it's a very physical process. You have this big ball of prostate that you have to take out in very, very small pieces, and the adenomas are very different in density and in strength. So they are all relatively similar. I don't think there has been any game changer. I would like to see drops in price, and that at least would be an advance.
Now, in our institution, we are working with 3 different morcellators, and many times I have all of them in the OR, because sometimes, don't ask me why, I am very fast in the beginning with one, but then it is not eating the ball, and then I have to move to another one, and then it is working much better than the other one, and then I can't understand why one morcellator is working better than the other one. Which one is your clinical practice? Do you are always working just with one morcellator? You have several morcellators? You change the morcellator if you don't feel comfortable? What are you doing?
We have 2 morcellators, the Piranha and the VersaCut, and without any evidence, I would say that where the adenoma is hard, you need very good suction, but when the adenoma is not hard, you benefit for higher speed. So multicut has better speed but worse suction, so if the adenoma is soft, multicut will be better. If the adenoma is hard, Piranha will be better. That's my opinion based on absolutely nothing. but I usually don't change. If I say like, I'll get a piranha, I'll get a multicut, and I'll finish the procedure with this one. Unless it stops functioning, I don't change morcellators.
Well, if I can comment on this, it's just like the laser and the stone, not the prostate. It's very unlikely that you start a morcellation and you have the same setting during that morcellation.
Ah, yes.
Because you have to change setting when the pieces are harder, when some part of the prostate is harder, when it's floppy, and the crucial point is absolutely the suction. So you have to keep an eye on your nurse, that keep an eye on the pipe, on the connection, on the cap connected to the vacuum. So it's a sort of having a team that actually is relaxing because you have done the enucleation and the patient is not bleeding, but you start another procedure that has a lot of pitfalls and need to be adjusted not to the adenoma of the patient that you are operating. And so anytime, and we will see after the live surgery, there's a section about the NIMER in enucleation, and the big part of the NIMER of the enucleation are about morcellation.
Fully agree. Other thing that many times happens to me is that I am trying to do the morcellation of these beach balls. Sometimes they are not so small, they are bigger, because as smaller is the ball, it is harder and it is more difficult for the morcellator to bite it and to destroy the ball. So many times I get nervous, I cannot, you are behind the ball trying to suction, and then I always have the resector on the table, and then I put the resector into, and then I try to resect the ball. But that is dangerous because many times you are trying to do the bite to the ball, and then what you are doing are holes in the bladder, and it's difficult. Which one is your strategy for this? Do you use the resector monopolar, bipolar? When do you use it, or what do you do?
I use it less and less as the morcellator have improved, but when I have to use it, definitely bipolar. Monopolar, you will have to press the adenoma to the bladder wall to have a circuit, and this is dangerous. And one thing I can recommend on this is, especially when you have a big bitch ball, get the resectoscope, cut it a little bit, destroy its structure, and then go back to the morcellation. Because usually when you do damage to the bladder is when you have small fragments that move a lot, and then I go back to the morcellation. Usually when you break in this structure, then you can morcellate again, and it's much safer.
Well, he has said it is really important. The important thing is that when you have the ball and you cannot do the morcellation, when you take the resection, not try to resect the whole ball. What you need is to make holes and to make disruptions in the ball, so it is not so elastic, it is not so hard, and then the morcellator can work again, and then you can morcellate again.
Absolutely.
I fully agree with that.
Many people say, like, I'm done with the morcellation. Now the resection all the way to the end, and it's not the best.
I have another question because...
But in any case, I remember 10 years ago when you started at Alfredo, you spent more time destroying the tissue than in the enucleation.
Absolutely.
So clearly we have very important improvements in morcellation, and for me probably it's more important the change, the improvement in morcellation in last 5 years than in the changes of the laser. Do you agree?
I agree that there was nothing until 5 years when all the new morcellators started coming out, but they haven't really changed the game completely. None of them really. Some people have better experience with one, with other, but there's no, like you haven't cut in 1/3 the morcellation time with the new morcellators. It's not a dramatic improvement that completely has changed morcellation with the new morcellator. That is still lacking.
I am fully agree with you, Carlos, that we have improved a lot the morcellators, because do you remember the first cases that we were there betting and beating the balls. And now the morcellators are better, but we still have a big space for improvement for the morcellator.
Definitely.
And for that reason, in our institution, we decided to move, and for very big prostates, now we are doing simple robotic prostatectomy. Because for very, very big prostates, sometimes you have a very big ball in the bladder. You don't have enough space in the bladder because the ball is just taking all the space into the bladder. The ball is hitting the wall. The wall is becoming with edema. It is bleeding. You cannot see very well. It takes a long time. You are in the urethra, playing with urethra for 2 hours, so we are afraid of urethral stenosis. So we are moving to some cases to a simple robotic prostatectomy or lab prostatectomy. Me robotic, Ricardo lab, because I don't let him the robot. No. So which one is your experience on your theory about this?
It's definitely an option. It depends on the experience of the surgeon on many things, but we shouldn't rule out any techniques. And if you're more comfortable and you feel it's safer with the robotic, it's an option. There's also an option to do the procedure in 2 steps, to leave a catheter for 48 hours, and the adenoma will rot and it will be very soft to morcellate, and then you can go with high-speed morcellation and be much more efficient. It's an option, but this is not perfect. And when it's not perfect, there's space for other techniques, definitely.
Are there, yeah, we have a comment on that.
Just to say that we are about to publish work on the saber blade, because we tried the saber blade in our hospital and we made a comparison with the Piranha Morcellator.
Great.
The work is already written, but I hope it will be published in a few months. And actually we found that the enucleation efficiency was, the morcellation efficiency, was comparable with when prostates were lower than 100 grams.
Between the 2?
Yes.
Cool.
But above that cutoff, the efficiency was higher with the saber blade. The difference...
With the cyber blade?
With the saber blade. The absolute difference was not so high in terms of numbers, but the difference actually was significant, statistically significant.
So the cyber blade is more efficient than the Piranha? That is a surprise.
Actually, is
Because I'm one of the user, and actually it's at the very start when you started using it, I mean for the first 10 or 15 Ks, you have the impression that it's too fast, and this allows you to lower down the speed of your morcellation. I mean, all the round I have per minute. At the end, it's just something that you don't have to concern about that, and you just to step up with your velocity. So you can be faster and faster, and actually, given to the fact that you have all in your handpiece, as it's just something that you attach to the suction, it's something that has no malfunction, and so it goes very rapidly. And it's very unlikely that is losing the piece during the morcellation. So this is what I felt, and I was using Piranha I'm using Piranha since 2010, so it's something that at the very start you feel is not good, then you keep on and say, okay, I'm using, he's using, another one is using, and actually you become confident, and it seems that it's quite equal, and sometimes it's better. So it's, but I do think like you and Javier, we need to think out of the box. Actually, this procedure with this kind of instrument to retract the prostate outside the urethra is something that needs a morcellator. I mean, a man who do the morcellation better than a man who do the enucleation. It's better to have a good morcellators than a good enucleators, because it's a very tricky part of the whole procedure.
I agree with you.
We have time for additional comments. Yeah, just the last one, and then we connect with the OR number 1 because it's ready to start. Just one comment.
Yes, so very nice presentation. Yesterday we discussed it during the dinner. So one maybe a small recommendation to the colleagues who starting their experience with endoscopic inflation of the prostate. So when you see that there is a bleeding and the visibility is not so perfect, so don't push it forward. So the main option and the main goal is our patient. So put the catheter, stop the bleeding, and do morcellation 2 days later. So this is an important advice for everyone who started. So think about the patient. And the last but not the least, so of course morcellation is a preferable option for removing the tissue, but we should not forget about other options, and they are still alive. So now, for example, if I have a huge gland and I have combined stones, I do enucleation and then I do a cystotomy, remove these stones, remove the adenoma, close the wound, put the catheter instead of 1 day for 3 days, and that's it. So I minimize the time of my endoscope in the urethra, minimize the time of the surgery, and this is also an option. So don't forget about it. And we see the publications now, even from Teva or from other teams, that they use this approach and it's effective and safe. Thank you very much.
Absolutely, thank you.